So I also start with a picture from the city that you so well know, your city, during one of my visits to Padua. And unfortunately, there was no visit this time, but I hope to catch up one day. So we agreed that I would speak on Brugada syndrome, whether that is a cardiomyopathy or a channelopathy. And just as a brief introduction for those who are not that familiar with Brugada syndrome, it is a disease that presents with a signature EKG sign, and that EKG sign is right precordial ST segment elevation and leads V1, V2, occasionally V3. It carries a significant risk for malignant ventricular arrhythmias that may lead to sudden cardiac death, and that is usually nocturnal, so in the night. And the diagnosis of Brugada syndrome is something that we do all agree on. These are the right precordial leads, lead V1, V2, 3, 4, 5, 6. And the abnormality in the EKG is here. In lead V1, V2, there is ST segment elevation, so elevation of the line above the baseline, and it should be at least 2 millimeters, as we have discussed in these meetings that Domenico just pointed to. So V1, V2. This is a type 1 EKG, and this is the only EKG that is diagnostic for Brugada syndrome. Occasionally you find the type 2 and the type 3, but you also find those EKGs in individuals who do not have Brugada syndrome. But there should be some suspicion, particularly if you have this EKG in a young male who had just a syncopal event. The suspicion for Brugada syndrome should be there, and you should try to see whether this EKG shows up with a drug test, for example. There are many controversies in Brugada syndrome, and because I only have 25 minutes, I cannot discuss all of them. But the pathophysiology of the EKG will be discussed during this lecture. I will not touch the genetic basis of Brugada syndrome. I will not touch the risk stratification. And if you allow me some time at the end, I would like to make a few comments on who actually described it first. So the pathogenesis for Brugada syndrome is either subdivided in a repolarization disorder or a depolarization disorder, and that is when it is in the setting of a channelopathy. So the repolarization disorder is something that is in a schematic drawing like this. You have the right ventricular myocardial layer that has an epicardium, that has a mid-mural layer, and an endocardium. And the EKG is the resultant of the transmural current flows across the ventricular wall. And in the normal situation, the action potential in the epicardium looks like this. In the mid-myocardium is a little bit longer potentially, and in the endocardium it looks like this. And that would give you an EKG which is normal for lead V1 or V2 like this. In the setting of Brugada syndrome, the idea is, and I'll show you in a minute where this idea comes from, is that the epicardial action potentials are abbreviated, the mid-mural layers are normal, the endocardium are normal, and because there is abbreviation here, there will be a current flow from endocardium to epicardium, and that will be picked up by this EKG that is overlying the epicardium up here by ST segment elevation. And if the action potential look like this, so there is an initial abbreviation, but then a prolonged plateau phase and a prolongation of the epicardial action potential longer than the endocardial action potential. Then at the end, the current flow will reverse and it will lead to ST segment depression in the precordial leads. And this actually is the EKG that you see in a Brugada syndrome patient. So potentially due to higher plateau phase in the endocardium compared to the epicardium, leading to transmural flow from endo to epi, picked up by and seen by ST elevation. And at the end of the action potential, there is a reverse of the current flow, which leads to ST depression. Now, all these studies that show this mechanism are arterial perfuse wedge preparation from the right ventricular wall. This is a piece from the right ventricular wall that is perfused. An EKG is made across the right ventricular wall, and action potentials are measured at the endocardium, at the mid-mural layer, and at the epicardium. And all this comes from the laboratory of Charlie and Silovich, originally in Utica in the United States, in the state of New York, and later in Philadelphia. And here again is this particular experimental setup. So an endocardial action potential, an epicardial action potential, and one more. In the control situation, a normal EKG. And when there is, in this case by drugs, a change in the morphology of the action potential, you get the current flow from endo to epi, which will be picked up by ST elevation. If this gets more, there will be more ST elevation. And occasionally you will get extrasystoles coming out of these abbreviated action potentials, and that will be the first extra. And if that continues, there might even be a polymorphic ventricular arrhythmia as the result of this inhomogeneity in repolarization. EKG then will look like this. This is an arrhythmia and like this. The alternative hypothesis is a depolarization disorder, and that has been put forward by our group in the past, about 20 years ago now, 15 years ago now. And that is roughly similar idea, but now based on depolarization disorder, conduction delay. The epicardium is activated much later than the endocardium and the mid-mural layer. That also leads to current flow from endo to epi during this phase. And if the delay is even further, it might actually also lead to ST depression. However, you need significant delays, 150 milliseconds or even 200 milliseconds. And this is another picture that we published in 2005, where the RVUT is the area that is of interest. The conduction delay occurs there. So there is a delayed action potential in the RVUT area that leads to the ST segment depression. And whether this is normal tissue or whether this is depolarized tissue in the RVUT area is still open for debate, but also in the case when there is not normal activated tissue, but slowly activated tissue, as depicted here, it will lead to the similar type of EKG. So you will have current flow through the myocardium from the RV to the RVUT. It comes out there, it gives you the ST segment elevation, and in the later phase, it leads to the ST depression. Now, the studies of Dr. Nadamani in the early 2010s, and so the last decade, actually show some very interesting data. He had patients with a lot of ventricular arrhythmia episodes, ventricular fibrillation. Dr. Nadamani is an interventionalist in electrophysiology, so he likes to ablate, and he did put catheters in the ventricles of these poor people, men in particular. And he did not find any abnormal signal in the right ventricular, at the right ventricular endocardial sites. And then he decided to go with the catheter to the epicardial site. And this is what he demonstrated. So this is from the outside of the right ventricle. This is the right ventricle. This is the pulmonary artery. This is the aorta. The red here is the aorta. And he measures signals over the right ventricular outflow tract. You are here on the right ventricular outflow tract. And these signals are very abnormal. There is a lot of delayed activity in this particular area of the heart. This is the whole right ventricle, same picture. This is the right ventricle. The yellow here is the pulmonary artery. And the measurement of the local electrical activity is here. And you see these very fractionated activity in all the signals that are in this area, the right ventricular outflow tract area here and here and here. But the further down you go, the more normal the signal becomes. This is a normal activation signal in the lower part of the right ventricle. Here it's normal, here it's normal, here it's normal, and also in the left ventricle, it is completely normal. So the abnormality is only there in the right ventricular area, and it consists of very delayed activation of the electrical activity is very delayed in that particular area. He also combined the measurements with endocardial measurements. So this is the epicardial measurement at this site, and at this site is the endocardial measurement. And as you can see, it's completely normal here, and it's very abnormal at the outside. He subsequently ablated that area with abnormal action potentials or with abnormal electrical activity. And this is before ablation in a patient, and you see the marked ST segment elevation here in the right precordial leads. And after ablation, you see that the typical Brugada sign, the signature EKG, has completely disappeared, and it's still abnormal, but that's due to the acute injury. But the ST segment elevation is gone, and these patients are subsequently free of arrhythmias. So the conclusion of this study is that only at the epicardium of the RVUT one finds late to very late potentials and low voltage signals. And ablation of these signals normalizes the EKGs and prevent future arrhythmic events. Now, Dr. Papone in Milan also started doing this, and he actually started doing this on a pretty large scale. Already in 2017, he had performed 135 procedures in Brugada syndrome patients, and in the meantime, it is over 1,000, I think. But he does find very similar signals. Here is the baseline EKG, not that much abnormality here, by the way, but still some abnormal signals in that particular area. You see the abnormal signals here. And if you give the patient ashmalin, that is a way to unmask the EKG, you see the right precordial ST segment elevation clearly there. And the area of abnormal signals, that is this purple area, becomes much bigger. The abnormal signals are here, and the area has increased significantly by the administration of ashmalin. So the summary of these 135 patients is some received flecainide, others received ashmalin. But anyway, flecainide extends the low voltage area, epicardial area, significantly from 19 square centimeters to 27 square centimeters. And ashmalin also extended that area. It did more so in males than in females. And interestingly, it also more extended the area in symptomatic patients compared to asymptomatic patients. So Dr. Ancelovic and his group also looked at this, at these data, and once again they postulate that abnormal repolarization is actually the basis for these late potentials and also for these fractionated electrograms recorded from the epicardium. So once again, this is the model that I showed you before. This is the heart from that Ancelovic studied, and the signals, I have to admit, are pretty similar. And this is then his explanation. So if you have these secondary upstrokes, which is the first extrasystole of an arrhythmia, that might deflect on the bipolar EKG as a secondary deflection, so it's late activation. And sometimes you even have two upstrokes, then you have two late activations, two deflections, and sometimes also here you have two. The difference between this and the studies from Nadamani, however, is that this is no low voltage. These are full upstrokes, so these signals are similar to the initial upstroke. The other point is that if you have a true arrhythmia, like here in panel B, then you have really fractionated activity over the area. But this is an arrhythmia, and this is not a stable state. And the explanation here may be correct for this particular signal in this particular model. But if you would take this to the whole heart, then you would have a very highly proarrhythmic substrate, and yet the EKG changes and these epicardial fractionated activity is stable for years in patients with Brugada syndrome with a type 1 EKG. And that is incompatible with this substrate or with this explanation, because it is only there and so fractionated when there is a significant arrhythmia, and there is not a significant arrhythmia day after day. So when I come then to the explanation of a cardiomyopathy, I start with the data from the Padua group, from Gaetano and Cristina, where they, but also a group in Rome, and case report from our group. There is never a normal, completely normal heart in a patient with Brugada syndrome who died. And also imaging data, data from Japan, data from Mannheim in Germany, and data from our own group, show that there are always abnormalities in the right ventricle. The right ventricle is always a little bit enlarged compared to normal values. And sometimes even the left ventricle is abnormal. Once again, Dr. Naramani, in collaboration with the group in St. George's in London and our group, we studied 6 whole hearts from such victims with a family history of Brugada syndrome. So these patients died from sudden unexplained death. There were no EKGs available in these patients before they died, but one of their first-degree family members had a clear Brugada syndrome. And then you may assume that the patient who died might also have had Brugada syndrome. These 6 hearts were compared to 6 control hearts. Mary Shepherd is here the esteemed pathologist. And in these hearts, there was more fibrosis and there was less connection in the right ventricular outflow tract area. And I'm going to show you the 6 examples. At the left side are the Brugada hearts, the right ventricular outflow tract area. At the right side are the controls. And here, in the first control, it's particularly the epicardial layer where there is a lot more fibrosis in the Brugada syndrome hearts compared to the controls. That is in all these 3 cases. And it is also true in the next 3 cases, so patient 4, patient 5, and patient 6. There is always more fibrosis in the Brugada patient than there is in the control patient. And this is an interesting heart, also in the same study. This is a patient who had surgery before, and then you cannot do the epicardial ablation because the pericardium is attached to the heart, and there's no pericardial space, so to say. So what this is an open heart procedure, an open chest procedure in a patient with Brugada syndrome. The signals are local application of the electrode on these particular areas. This is the right ventricular outflow tract once again. You see the very fractionated activity all around the place here. And then at the side, these sites are ablated, and at one point a biopsy is taken, and that is right in the middle here, in the middle of all this fractionated activity. And you see also that the further you go down, the normal the signal becomes. But if you then look at the biopsy, then you see once again a thick layer of fibrosis overlaying that particular area of the epicardium. And also in the epicardium itself, there is epicardial and focal replacement fibrosis in this heart. So based on that, I think the pathophysiology of Brugada syndrome, it can be concluded that ST elevation is the result of a conduction delay, and there is a potentially significant role of fibrosis in that particular area of the heart. But the conduction delay may also be present at different areas of the heart. For example, at the level where the Purkinje fibers connect to the ventricular muscle, that is always a high resistant area. And when there is somewhat more fibrosis, the resistance might even be more, and there will be more conduction delay, but we have not shown that. So that is the talk on Brugada syndrome, and I think I have a few more minutes to discuss some of the history. And that is the question, who actually described Brugada syndrome first. There is a paper from Padua, from Andrea Nava and Bortolo Martini in 1988 in a patient with some structural heart disease. This is a picture, obviously, from Padua. You will recognize the streets in Padua. And Dr. Nava and Dr. Martini are at the right side of this slide. And this was the paper in a French journal in 1988. And it is about the EKG in this particular patient, or in a patient with a clear Brugada pattern. And it's about the vectorcardiogram, and the hypothesis here is that there is conduction delay in some of the branches of the right ventricle conduction system that leads to this EKG. This patient is also part of this famous paper in the American Heart Journal in 1989 by the same group of authors. But in the paper is the description of the pathology of several of these hearts, of endocardial biopsies. And although the title is without apparent heart disease, all these patients had some degree of structural heart disease. And number 3 is the patient with the clear Brugada EKG, and number 3 is also the patient published in that French paper that I just discussed. Now, in 1992, Pedro Brugada and Joseph Brugada published 8 cases, and they hypothesized that this EKG was based on a pure electrical disease. And then a few years, this is their paper in 1992. And then in 1996, 4 years later, Dr. Chen and colleagues, including the Brugada brothers, disclosed the SCN5A variants in 2 patients, I think. And because SCN5A is an ion channel, the hypothesis was ion channel variants in SCN5A lead to a pure electrical disease, and that is not a structural disease, so that is not compatible with the earlier papers. And then others start to mention this Brugada syndrome, and I think everyone at that time, except Dr. Martini, considered the case closed. And then if you summarize the data from the last 15 years or last 20 years, then it's clear, and I've showed you the evidence, that there's more and more evidence for conduction disease, actually, not repolarization issues. And there's more and more evidence for structural abnormality. And the hypothesis we actually have is that the channelopathy, it might actually start as a channelopathy, SCN5A related channelopathy, might ultimately lead to a cardiomyopathy, and that then in this case is a local cardiomyopathy in the right ventricular outflow tract. And therefore, I do believe that Brugada syndrome is not a pure electrical disease. It is more of a discrete local cardiomyopathy, and that for me and for our group actually questioned the used terminology. I think Brugada syndrome is simply not correct. There were others, and the others were in Padua who described this first. So thank you very much for your attention. I would be pleased to address any question. If you are interested in this history, in this book, Dr. Martini did write an interesting chapter with an intriguing title, A Rare Lethal Syndrome in Search of His Identity. And obviously, this holds the story that I just told you, and I actually think he is correct. So thank you very much for your attention.